the basic unit of the liver is the liver lobule, which is a hexagonal structure like this. And there are other hexagons emerging from it. At the angles of the hexagon, at the angles of this hexagon is a triangle. It becomes like this, and it has got an artery, a bile duct, and the portal vein. Let us make the vein here. Let us increase the size of this and let us make the vein here. Okay. In the center, you have the hepatic vein. From this to the hepatic vein, there run basically two layers of liver cells. And in the center, these cells give rise to what is called as the biliary canaliculi. And these biliary canaliculi, joined from all these cells, form the bile duct which drains into the biliary system. So there is a duct system between these layers of cells, and between such layers of cells is the sinusoid. So you have a sinusoid here where there is blood, and you have a sinusoid here where there is blood, and in this sinusoid, blood from the portal vein passes into the hepatic vein on one side, and arterial blood basically passes and keeps supplying these cells with oxygen from the hepatic artery. So this is the basic structure of the liver, and as you know, this portal vein is coming from the gut, having nutritional products, which means glucose, fat, and proteins, which are metabolized by these cells, stored to some extent, and given as per need into the portal vein. The artery is meant to keep these cells alive by giving them oxygen and glucose. The products in the blood here, which are waste products, are also metabolized, converted, and sent back through the hepatic veins, and some of the products are released through the biliary canaliculi and are drained through the bile duct into the intestine. And these products that are drained into the intestine through the bile duct are basically products of red cell destruction, where hemoglobin of the red cell is converted into indirect bilirubin, which is gluconated in the liver and converted into direct bilirubin, which is excreted in the bile duct and in the duodenum, in the intestine. It becomes urobilinogen and stercobilinogen, which gives color to the urine and the stool. Besides this, bile salts also are secreted through the bile ducts into the intestine and are lost in stool. So this is the basic structure of the liver, histological structure of the liver, and then we will move on to understanding the gross structure of the liver as to how this liver is supported. And as you know, the liver lies in the right hypochondrium. It lies in the right hypochondrium under the diaphragm, and it has got a right lobe, a left lobe, and a caudate lobe. So if you look at the inferior surface of the liver, it has got a diaphragmatic surface, anterior and posterior, and it has got an inferior surface. Inferior surface is divided by, if you look at the inferior surface, it is divided by a H-shaped fissure into a right lobe, a left lobe, and a caudate lobe. Into this lobe, attached like this, is the free edge of the lesser omentum, which goes and forms the coronary ligament. This part forms the coronary ligament, comes back from its superior surface, forms the falciform ligament, the right coronary ligament, and then comes back and attaches to this part of the lesser omentum. So this is how the peritoneum supports the liver, and in the free edge of the lesser omentum you find the portal vein, the hepatic artery on the right side, and the bile duct. So you find the portal vein, the hepatic artery, and the bile duct. Behind you find the inferior vena cava, and through this gap between the free edge of the lesser omentum and inferior vena cava, this is called as the foramen of Winslow, and through this you can enter from the greater sac to the lesser sac. So this generally is the gross anatomy of the liver. And now we will outline the functions of the liver. So what is coming from the intestine? The glucose is either stored as glycogen, which can it also be converted into glucose, which is sent into the cell, and in this cell it undergoes the 6 carbon atom glucose becomes the 3 carbon atom pyruvic acid, which in the anaerobic phase gets converted into lactic acid when there is no oxygen, when oxygen is absent, or goes through the Krebs cycle and through a proton pump to create energy. If this mechanism, which is dependent on insulin, either because of deficiency of insulin or because of resistance to insulin, fails, then the Krebs cycle is fed by acetoacetic acid here, and acetoacetic acid, 11-hydroxybutyric acid, and acetone are derived from the liver by breaking fatty acid, by breaking fat. And this fat has moved from the stores of fat through the arteries, has produced atherosclerosis in the arteries, and therefore there is renal, retinal, cardiac and cerebral effects of atherosclerosis, which you see in insulin failure or diabetes mellitus. Also you see that since acetone is produced, therefore there is diabetic ketoacidosis. On one hand, the glucose doesn't enter the cell, it cannot be used. On the other hand, the glucose becomes higher in blood. On the third hand, fat is burnt, and fat is burnt, which means that there is ketoacidosis, and which means there is a fatty liver, and which means that there is atherosclerosis, which causes renal, retinal, cardiac and cerebral involvement or vascular insufficiency in these 4 key cardinal areas. So this is about glucose. The second thing that the liver deals with is protein, and basically protein is converted into uric acid. Uric acid can cause gout or arthritis. There is another product which can cause hypertension because it causes vasospasm. So carbohydrate, protein and fat are basically absorbed from the portal venous system, either stored or converted into usable forms which are used for cell function. One very important thing about the liver is that it produces prothrombin from vitamin K. Therefore, all liver diseases can present with coagulopathy, PTPC, prothrombin time, prothrombin concentration should be measured in liver disease, and vitamin K can be given to substitute liver dysfunction. So, this is about the function of the liver. Now, supposing there is liver disease, what can it present as? So, the first thing is it can present as hepatomegaly. Either it can be smooth or it can be nodular. Single nodule or multiple nodules. Now, it can be tender or not tender. It can be soft, it can be hard. So, hepatomegaly, a smooth non-tender hepatomegaly is basically can be a fatty liver. A smooth tender hepatomegaly can be in congestive heart failure, can be in amoebic hepatitis, or amoebic liver abscess. And also in other hepatitis. But in other types of hepatitis, which are viral hepatitis, this tender hepatomegaly is usually associated with jaundice. So, a single nodule in the liver could be a liver abscess or could be secondaries or could be carcinoma of the liver. Liver abscess is usually amoebic. Multiple nodules are usually felt in secondaries or they are also felt in cirrhosis. So, we have put tender and non-tender here. Then there can be very many other reasons of hepatomegaly, and they are because of reticuloendothelial proliferation. In malaria, filaria, leishmaniasis, and glycogen storage disease, or even lymphoma and leukemias. All right. So basically, what you have to think of in hepatomegaly is smooth or nodular, hard or soft, tender or non-tender. And of course, there is a technique to feel the liver. Liver is a lump in the right hypochondrium which moves with respiration, with a lower border which is parallel to the subcostal margin. You cannot insinuate your fingers between the lump and the subcostal margin. And the difference between a liver lump and a gallbladder lump is that the gallbladder lump has a vertical boundary, whereas the liver lump, the boundary is parallel to the subcostal margin. So, hepatomegaly is one presentation. Splenomegaly, because of back pressure, ascites, hematemesis through the portal vein, esophageal varices, and melena are because of cirrhosis and portal pressure. Jaundice, excess bilirubin in blood. can be prehepatic because of excessive hemolysis. When the indirect bilirubin is increased, because when the red cell is destroyed, the bilirubin is indirect. Then it can be hepatic, and hepatic is because of either cell damage, cell dysfunction. Supposing the cell is not able to conjugate bilirubin, it is in certain congenital conditions, enzymatic defects, and there are two syndromes associated with it, the Crigler-Najjar syndrome and the Gilbert syndrome. The cell damage can be because of hepatitis, viral hepatitis, and you have A, B, C and E viruses which can produce hepatitis. The B hepatitis is more dangerous, more fatal, but transmits by only parenteral route. Whereas A has an orophycal transmission, therefore it's more common but less dangerous. The C hepatitis is usually the chronic variety, and it basically doesn't damage the liver by the viral load, but damages it because of the immune reaction against the virus. So these are the various types of hepatitis. Viral is one, alcohol is the other, and fatty liver is the third, and poisons are the fourth. Drugs and poisons are the fourth reasons why the liver cell can be damaged, and the damaged liver cell can cause increase in the enzyme SGOT and SGPT. But besides this, there is edema in hepatitis. Therefore, there may be a tender hepatomegaly. There is loss of weight, loss of appetite, and usually what you have to very seriously look for is hepatic coma or hepatic encephalopathy or ammonical encephalopathy. And one of the first signs of hepatic encephalopathy is constructional apraxia. If you ask him to draw a star like this, he may be able to draw it somewhat like this. So you must carefully watch for liver failure in cases of hepatitis. Otherwise, it usually recovers on its own. Another reason of jaundice is not only cell failure, but also because of edema. There is pressure on the biliary canaliculi, and therefore the jaundice is cholestatic. But this is intrahepatic cholestasis. Because of the intrahepatic cholestasis, the conjugated bilirubin gets into the blood and the Vandenberg reaction becomes biphasic. The alkaline phosphatase increases and urinary urobilinogen becomes absent. And since the stercobilinogen in the stool is also absent, therefore stool becomes clay colored. So there is intrahepatic cholestatic jaundice in hepatic cause of jaundice. And then of course there is a post-hepatic jaundice where the obstruction is in the biliary duct, and that post-hepatic jaundice is primarily because of two reasons: the gall stone or cancer, which is painful, recurring attacks of biliary colic with a gallbladder lump. When one of the stones goes into the bile duct, there is this jaundice. And as you know that the bile duct and the pancreatic duct are here, and the ampulla vetra here is here, and this is the duodenum. Therefore, if the stone lodges here, the bile will go back into the pancreas, the pancreatic juice will be activated, and there will be associated pancreatitis and pancreatolithiasis. And pancreas can release a lot of fluid into the lesser sac. Therefore, there can be a pseudo pancreatic cyst. Now, so one is this problem with the gallbladder, either a cancer or a stone, which can produce this combination of what is called as obstructive jaundice. The bilirubin is direct bilirubin, conjugated bilirubin in the blood. The urobilinogen is absent in the urine, the stercobilinogen is absent in the stool, therefore you have clay colored stools, and you have lots of bile salts into the bloodstream, causing a lot of itching and pruritus. The second is the jaundice because of this carcinoma, head of pancreas, and this is painless, progressive jaundice. And this is because of carcinoma, head of pancreas. So to summarize, jaundice can be prehepatic, which is hemolytic, indirect bilirubin is increased. It can be hepatic, in which the cell enzymes are released into the bloodstream, and because of intrahepatic pressure on the intrahepatic biliary canaliculi, there can be a cholestatic jaundice and increase in alkaline phosphatase and features of some obstructive jaundice also. Then extrahepatic causes of obstruction are the stone in the gallbladder or a cancer in the gallbladder which has gone into the bile duct. It can produce obstructive jaundice, but if the obstruction has gone into the ampulla of Vater, bile will go into the pancreas and cause pancreatitis and pseudopancreatic cyst, activating the enzymes in the pancreas within the pancreas. So, after this this obstructive jaundice or this liver cell dysfunction, we can go to the liver failure when the entire metabolism fails and there is cerebral edema and encephalopathy. And when all this phase is over, liver heals by fibrosis and regeneration. If regeneration wins, the patient is cured. So there is regeneration of the liver cells, the patient is cured. But if there is too much of fibrosis, then you go to chronic liver failure and you go to portal hypertension. Now this portal hypertension causes a splenomegaly, causes esophageal varices, and can cause piles and can cause ascites. Now splenomegaly you can palpate and you can measure the portal blood pressure, which is called as portal wedge pressure. Portal wedge pressure through the enlarged spleen. For esophageal varices, you can have hematemesis and melena, and you can have bleeding piles. And of course, you should look for ascites, and because of protein deficiency, you can have pedal edema. So this is the picture of cirrhosis and chronic liver failure. So this finishes the clinical approach to a case of liver, and then we will deal with management in the separate lecture. दिखाओ भाई क्या हुआ.